We're not going to briefly talk about immunotherapy, actually endometrial cancer, but truly immunotherapy and how that has transformed the management of this illness. I emphasized in a previous segment that the way we treated endometrial cancer from a systemic perspective was basically how we treat ovarian cancer. Nothing could be further from the truth today. The backbone from a systemic perspective remains carboplatin and paclitaxel, still very active drugs. But the role of immunotherapy has now become incredibly prominent in a very positive way. However, there are multiple questions. Which drugs do you use? Does it make a difference? Perhaps yes, perhaps no. Where are the comparative studies? How long do you give the immunotherapy? What is the specific role of a variety of proposed biomarkers in immunotherapy? Is it relevant today to know if a patient has mismatch repair deficiency? Or should all patients, for example, in the metastatic recurrent setting, get an immunotherapeutic agent? What is the role of the biomarker PD-L1? And increasingly, because of very provocative data where PARP inhibitor has been used, what is the role, not of necessarily of knowing if a patient has a BRCA mutation, because the percentage of patients is probably relatively low in this setting, although I don't know, we know for sure. But what about homologous repair deficiency or other types of biomarkers that might indicate a PARP is relevant? Do we get these tests? Should we get these tests? Should we make decisions based on this? And of course, we have some also provocative data, not standard of care yet, about the potential relevance of the use of therapy or therapies that are determined by whether a patient is a p53 normal or mutated status. Where is that going to be in our paradigm? What about in the second line setting? If a patient develops a recurrence, do we repeat the therapies that we gave before, immunotherapeutic agents? What about chemotherapy agents? And I have to then add, this is actually a different population from the population of women with ovarian cancer. There are a limited number of patients, therefore it's harder to do trials. As we know, historically, this is a population often that's older than ovarian cancer, population that has comorbidities, diabetes, high blood pressure, obesity, heart disease. So the studies that are done, the trials that are done, where the patient population absolutely does not even remotely represent the real world population, how do we translate those results into optimal care of patients that we are actually taking care of in the community? Again, we critically need decision support. We need pragmatic trials that are going to answer these questions, not just getting new drugs approved. I thank you for your attention.